Hi everybody and welcome back to NRS274 Module 2 on inflammation, infection, immunity and wound healing. This is the fourth installment and it's going to deal only with wound healing and the various phases of wound healing. So much like the inflammatory process, there's a story here. There are several steps that fit into place. So my top tip, both for inflammation and wound healing, is to draw some concept charts or flow charts so that you can see how each sort of section, each part of the response follows from the previous and leads to the next, because we've got a whole little fairy tale happening here. Okay, so the aim of wound healing is to restore the structural and functional integrity of tissue. So we've done something to damage the tissue. Here in the image, we've probably cut a finger, but look at that. So chopping some veg, accidentally sliced the top of the finger off, and we've actually got quite a bit of damage there. So you can see here as those images progress, that wound is really filling up with new cells. It's nice and, well, it's not nice, but it's very red to begin with. So lots of blood flow there, a bit of clotting you can see, stopping that bleeding. Underlying that, we'll get new cells forming to fill in that gap. And eventually over several days and weeks, they will reform functional tissue. So what we want at the end of wound healing is structural and functional tissue that behaves and looks as close as possible to the original tissue that was damaged. So wound healing occurs either by primary or secondary intention, which we'll get to in the next slide. Basically what that means is with primary intention, you've got a nice clean cut, a slice, and you can bring the sides of the wounds together, and they don't have a lot of cells then that are needed to fill in. They just kind of knit together, and it heals quite quickly and quite nicely and neatly. With secondary intention, you've actually gouged out some of the tissue and lost some tissue. So it could be physical gouging of tissue, or it could be that you've got an infection in there and that's destroyed some tissue through necrosis. In that case, you can't just bring the sides together. You actually have to regrow a number of cells to fill the gap, and that's secondary intention. Healing begins during the acute inflammatory phase and can last up to 2 years, depending, of course, on the nature of the wound, where it is, how much blood flow there is to the wound, etc. So when we talked about inflammation, I said it's super important for wound healing. Its main role is to clean up the site where you've damaged yourself, get rid of any bacteria, any cell debris, any foreign debris like splinters and dust and who knows what else, so that we can get that healing underway. So in summary, wound healing involves the processes that fill in, seal, and shrink a wound. So there's two overlapping phases with wound healing. First of all, we need to build up the tissue again, and this is the reconstructive phase. So first of all, we clean it out with inflammation, then we reconstruct. It begins 3 to 4 days after injury and continues for a couple of weeks or thereabouts. Again, it's a bit variable depending on where the wound is, how big the wound is, etc. How old you are even. Following that reconstruction of all of this cells, so the filling in of cells, we now need to mature those cells. So this is the maturation phase. It begins several weeks after injury and can go on for years, again, depending on the nature of the wound. And here we're reorganizing all of the cells that have infilled, making sure they're arranged as close as possible to the original that we're replacing, and function in the right way. There are two main types of healing, as I said, primary intention or secondary intention. Sometimes we'll say primary or secondary intent. So primary intent or primary intention is wound healing that occurs in areas with minimal tissue loss. So in our picture over here, and this one here, we've got a clean cut, I beg your pardon, as if you've made an incision with a scalpel. So you've got tissue that's been cut, and you can bring the tissue together quite neatly. And if necessary, you might suture that closed to hold them together. But there's only minimal number of cells you need to produce to bind those two sides back together. So it occurs in wounds where the dermal edges are close together, scalpel incisions, paper cuts, things like that. The healing is usually faster than secondary intention, and that's because you don't need to reconstruct a whole lot of tissue. Secondary intention is where wound healing is for wounds that tend to be open wounds, and they have extensive tissue loss, and the sides of the wounds aren't open. You can't really bring them together as such. So in this image, you've lost quite a bit of tissue. So you might have scraped away the tissue in a pretty nasty injury. Or, as I said, you might have an infection, and the necrosis from that infection has destroyed some of the tissue. So then you have to regrow it. What we see between primary and secondary intention, primary has minimal scarring, and they're usually pretty neat. So that scar here, the primary intention healing, looks like a fairly fresh scar to me. Over time, that will go through that remodeling or maturation phase and possibly even disappear, or at least become quite faint. Whereas secondary intention, because you've had to regrow and replace a whole lot of tissue, the scarring tends to be much more visible. Healing in secondary intention has to occur from the bottom of the wound upwards, because you're filling in that gap and filling in that hole. So you need a whole lot of fibroblasts to come in and create tissue, and then there's a lot more remodeling involved. Okay, so the two phases. The reconstructive phase has a number of parts. So first of all, the first thing we need to do is stop any bleeding. So bleeding is sealed off by forming a blood clot. And I mentioned platelets quite a few times in relation to blood clotting. They're those cell fragments that are in our blood. They react with fibrin. So fibrin are long strands of protein that mesh together and form like a lattice or a scaffold. And the platelets then fill in the gaps together with white blood cells and red blood cells, and that creates your blood clot. So it combines trapped platelets and cells to stop the bleeding. That sealing unites the wound edges, as well as creating a barrier to the outside world, so protecting against further debris infill or bacterial invasion. So the scab or the blood clot is really a seal, and then we can start healing from beneath. So the fibrin mesh acts, as I said, as that scaffold. First of all for the clot itself, but then also for the fibroblasts, which are cells that lay down new tissue, and collagen in particular. So we've got a scaffold here, and we're sort of backfilling with new collagen deposition that fills the wound and the clot. Our macrophages come along, they make sure the site is nice and clean, and they slowly dissolve the clot and clear away the debris and dead cells from the bottom up. Okay. Granulation tissue can occur, and this consists of connective tissue as well as the fibroblasts, and that grows into the wound. At the same time, we might get the growth of new blood vessels, bringing all of the things that we need to heal the wound. And we call this angiogenesis. So whenever you hear the word angio, as in angiogram, it relates to blood vessels. And genesis means creation. So we're creating new blood vessels. This occurs in the granulation tissue, and new lymphatic vessels can occur at the same time. Epithelialization occurs, or epithelialization, I should say. And this is where epithelial cells grow into the wound and unravel those collagen fibers secreted by the fibroblasts, and sort of start replacing the collagen with cells, so epithelial cells. So the collagen acts as a bit of a scaffold, a guide for those cells to then start infilling and slowly breaking down the collagen. Wound contraction then occurs after about a week to 2 weeks, and here the myofibroblasts contract their fibers, so those long strands begin to get shorter, and that pulls the wound closer together, makes it really tight. So it exerts tension on the neighbouring cells and anchors the wound bed. So if you've got a cut, you might have noticed, or maybe not, your scab that forms after a week or so, it starts to sit up a little bit as the wound gets tighter, and then it'll drop off. Or if you're like me, you tend to pick it up, which is not good practice, but you know, I'm a kid. Okay, so here we've got a little bit sort of a more graphic that shows this, as well as maturation. Oops, if I go back. So these phases here, first of all, we've got our damage here. We've got some inflammation coming to clean the site, our white blood cells. You can see the scaffold here from the fibrin, and the fibroblasts forming collagen, and that'll just infill here. It'll eventually be replaced by epithelial cells, which we can see here, and the wound contracts. So we've filled in the gap now. What we need to do now is make sure that that gap that we've filled in is arranged and functioning as close as possible to the original tissue. And that's where maturation comes in. And that can continue for months or years. So the collagen matrix assembly, that was the scaffold for those epithelial cells to arrive, continually remodels and rearranges so that we're trying to get things as close as possible to normal. We get a lot of tissue regeneration and continued wound contraction. If we've got a scar, that'll slowly remodel as well. And those blood vessels that formed with the angiogenesis will start to retract and disappear as well. So the capillaries disappear, leaving an avascular scar. So a scar without a blood supply. Now, as I said, the aim is to get it as close as possible to the original tissue. It's not always possible to achieve that. Sometimes we get some remnants, sort of weird looking collagen. We call this fibrous tissue, and that is scar tissue. So it's not quite exactly what the original tissue was like. It's pretty strong, it won't fall apart, but it doesn't perform quite the exact same function. So I briefly mentioned age as something that might contribute to wound healing, and there's a number of other factors that can contribute to wound healing as well. So dysfunctional wound healing can occur during any phase of the healing process. And that can involve insufficient repair or excessive repair. So we've overdone it, we've produced all this scar tissue, like keloid scars that we can't get rid of. Infection can also be a complicating factor, as well as just things like reopening a wound, bumping it continually. So it just keeps reopening because you put all this effort into the inflammatory response to clean up the wound, and then all of this cell growth to try and mesh it together and heal the wound, and then you've reopened it again. So factors that can affect wound healing can include malnutrition. So in order to grow new cells and produce all that collagen and fibrin and all of those things, our inflammatory response as well needs a lot of energy. So that needs the right nutrients. So if you're malnourished, you're really going to struggle to heal wounds. Sites that have high blood flow and really good oxygen delivery heal better. If you've got restricted blood flow and included restricted oxygen, the wound's going to heal really slowly. An example here, we've got peripheral damage to the toes. So this looks like frostbite to me, and gangrene following frostbite. So with frostbite, the cold has constricted the blood vessels. So these extremities here aren't getting blood flow and they're dying. Now, dying tissue can't really be recovered. It can't heal wounds. If you've got impaired inflammatory and immune responses, that's another thing that will impair the wound healing. You need to be able to clean the wound up to begin with before the wound healing can occur. Infection is a complicating factor. Wound separation, again, bumping, opening up the wound. Foreign bodies being stuck in wounds, because then obviously you can't get the tissue aligning nicely. And as I said, age. So children, healthy adults heal more quickly. As we age, everything becomes less efficient, and the same goes for wound healing. So our elderly citizens, they're not as good at wound healing. So we'll see, ulcers and damage and cuts and things last a lot longer. Okay, we'll finish off wound healing there. Our last installment will deal with infection and some of the infectious agents.